In this section, we will discuss mycology, or fungus and molds. Next, let's discuss systemic mycoses. All of the following can cause pneumonia and can disseminate. All of them are caused by dimorphic fungi, which means that they are cold at about 20 degrees. They're in mold form. When they're hot, about 37 degrees, they're in a yeast form. The only exception to this rule is with coccidioidomycosis, which is a spheral and not a yeast in tissue. Treatment for the systemic mycoses include fluconazole or ketoconazole for local infection, amphotericin B for systemic infections. Remember that systemic mycoses can mimic TB, you get granuloma formation, except unlike TB, there's no person-to-person transmission of the systemic mycoses. Once infected, you can get systemic mycoses, for example, histoplasmosis or blastomycosis. Let's talk about each of these. Histoplasmosis is endemic in the United States to the Mississippi and Ohio River valleys and causes a pneumonia. So what we see here are small 3 to 5 micron spores found within the cytoplasm of macrophages. Each of these spores is smaller than an RBC, so that can give you a good idea. If you're looking at a stain, compare it to a red blood cell. You'll see them smaller within a macrophage. So remember, histo hides within macrophages, and it's normally transmitted through bird or bat droppings. Blastomycosis is endemic to states east of the Mississippi River as well as Central America. It causes inflammatory lung disease and can disseminate to skin and the bone, where it can form granulomatous nodules. What you see looking under a light microscope is 5 to 15 micron spore that has budding. So it's about the same size as a red blood cell, but it looks like it's budding off. So you're going to remember that, blastobuds broadly. Coccidiomycosis is another systemic mycosis. It's endemic to southwestern United States as well as California. It causes a pneumonia and also can cause meningitis. It can disseminate to bone and skin as well. The case rate we've seen increase after earthquakes, which makes sense because the spherules of coccidiomycosis are thrown up into the air. What do we see when we look at the microscope? We see a spherule about 20 to 60 microns in size, so much bigger, filled with endospores. So how do we remember this one? Remember coccidio crowds, that spherule crowded with endospores. It's associated with San Joaquin Valley or Desert Valley fever. Paracoccidiomycosis is endemic to Latin America. Here on the microscope we see a 40 to 50 microns, so not quite as big as the coccidios can get. It's a budding yeast with a captain's wheel formation. So think about the captain's wheel of a boat. Remember, Paracoccidio parasails with the captain's wheel all the way to Latin America. That'll help you remember that. So here again to review, looking at the endemic areas will help you remember for the test which mold, which fungus they're talking about. So if it's southwestern United States or California, think coccidiomycosis. If it's Mississippi or Ohio River Valley, it's histoplasmosis. If it's east of the Mississippi, think blastomycosis. You also need to consider this when they're talking about Central America. If it's rural Latin America, remember paracoccidioidomycosis for that one. So let's talk about some of the cutaneous mycoses now. Tinea versicolor is one of them, caused by Malassezia furfur. We have the degradation of lipids that produces acids that damage melanocytes and cause hypopigmented patches. We see it typically associated with hot, humid weather. Treatment for tinea versicolor includes topical miconazole and selenium sulfide shampoos, or Selsun shampoos. On the microscope, what we see is the classic spaghetti and meatball appearance on the KOH prep, which you can see in the picture. The other cutaneous mycoses include tinea pedis, cruris, corporis, and capitis. These are itchy, pruritic lesions with central clearing that resemble a ring, hence the name ringworm for tinea corporis. They're caused by dermatophytes like Microsporum, Trichophyton, and Epidermophyton. What you see on the KOH prep is mold hyphae, not dimorphic. Pets are usually a reservoir for Microsporum and can be treated with topical azoles. Moving on to some of the opportunistic fungal infections, we'll start with Candida albicans. Remember, alba is white, so when you see something that's white, start thinking about Candida albicans, and we'll get to that. Systemic or superficial fungal infection. It's a yeast with pseudohyphae in culture at 20 degrees. It's a germ tube formation at 37 degrees, which is what we use to diagnose. Oral and esophageal thrush in immunocompromised patients. So we see this in babies, we see this in people that are on steroids, we see this in diabetics, and we see this in AIDS patients. Candida also causes vulvovaginitis, and that's due to high pH, diabetes, or use of antibiotics. We see Candida in diaper rash, and we see Candida in endocarditis in IV drug users. We can see disseminated candidiasis to any organs in immunocompromised hosts, and we also see an immunodeficiency called chronic mucocutaneous candidiasis for certain lacks of T cell subsets. Treatment for Candida albicans is nystatin for the superficial infections, amphotericin B for the serious systemic infection. So looking at the picture all the way to the left, we have the Candida. Remember, Candida are pseudohyphae with budding yeasts at 20 degrees, and then germ tubes, which look kind of like sperm, at 37 degrees. For Aspergillus, we think about the organism Aspergillus fumigatus. It causes allergic bronchopulmonary aspergillosis, or ABPA. It can cause lung cavity aspergillomas, or fungal balls, and it can also be invasive, causing invasive aspergillosis, especially in immunocompromised individuals and those with CGD. So if you know CGD, other than having those catalase-positive bacteria that we talked about in another section, they can also get infections with Aspergillus, especially Aspergillus fumigatus. So remember, mold with a septate hyphae that branches at acute angles, less than 45 degrees. So remember, acute angles in Aspergillus, and it's not dimorphic. What you see on the microscope is the picture second from the left. We have 45-degree branching angles with septate hyphae, and you can see rare fruiting bodies. You will not see budding yeasts. For Cryptococcus neoformans, we associate this typically with cryptococcal meningitis, but we can also see it in what we call cryptococcosis. Heavily encapsulated yeast, not dimorphic, so we don't see hyphae, we just see the yeast. Found in the soil, can also be found in pigeon droppings. We culture it on Saborod's agar, and we stain it with India ink. We use a test called the latex agglutination test, which detects polysaccharide capsular antigen, and we can see soap bubble lesions on the brain, which are also characteristic for cryptococcal meningitis. So here, second from the right, we see a picture, again, that yeast, heavily encapsulated, no hyphae. The next species is Mucor or Rhizopus. They cause mucormycosis. This is a mold with irregular, non-septate hyphae branching at wide angles in contrast to Aspergillus. So the disease is mostly in ketoacidotic diabetes and in leukemic patients is where we see this fungus. These fungi can also proliferate in the walls of blood vessels and cause infarction and necrosis of distal tissue. So we can see rhinocerebral frontal lobe abscesses as well. Looking at the right now and contrasting all of these fungi, we see the mucor here, again, irregular, broad, non-septate, branching at wide angles. Another common fungus seen on the boards is Pneumocystis jirovecii. You might know it by its former name, Pneumocystis carinii. This fungus causes a diffuse interstitial pneumonia. It is a yeast. It was originally classified as a protozoan, but later found that it had characteristics more associated with yeasts. It's inhaled. Most infections are asymptomatic and most often seen with immunosuppression like AIDS. You get a diffuse bilateral chest x-ray appearance. You diagnose it by lung biopsy or by lavage. It's identified by methanamine silver stain of the lung tissue. And treatment for pneumocystis is Bactrim, pentamidine, and dapsone. In HIV patients, we typically start prophylaxis when the CD4 counts drop below 200 cells per milliliter. Another fungus that likes to show up on the boards is Sporothrix shankii. It causes sporotrichosis or rose gardener's disease. The fungus itself is a dimorphic fungus that lives on vegetation. When traumatically introduced to the skin, typically by a thorn, it causes a local pustule or ulcer with nodules along the draining lymphatics, so you see ascending lymphangitis. It has little systemic illness. The yeast is a cigar-shaped budding yeast visible in the pus. So you can actually take a sample of the pustule and you can look at it under the light microscope and you can see this fungus. Treatment includes itraconazole or potassium iodide. And that concludes this section of the review.